Oh, I've been starting in urology actually in 1980. That's a long time ago, at the time where urology was endoscopy, minor genital surgery, hydroceles, circumcisions, stone retrieval with dormia extractions, and also transurethral resections of the prostate and of bladder tumors. By time we have become a major surgical discipline, actually, developing big surgery like cystectomies, urinary diversions. When I started and we had a diversion to do, we asked the abdominal surgeons to do it, and today we are doing vena cava thrombosis, we are doing retroperitoneal lymph node dissections, we are doing all intestinal surgeries, pouches with colon, pouches with ileal neobladders, for instance. And now you see again there's a move to minimal invasive surgery. So we were endoscopists and minor surgeons first, we became the big surgeons, and now we are getting to a minimal invasive era with robot-assisted laparoscopic surgery. And again, endoscopy becoming more and more important. So this is the most important change over the, let's say, 35 years. Last year, at the occasion of the Congress, we have had the European Prostate Cancer Center of Excellence consensus meeting, where we involved urologists, radiation oncologists, radiologists, nuclearists, patients, nurses, psychologists, medical oncologists, and we have come to a consensus of what a prostate cancer center of excellence in Europe should actually stand for. The most important is obviously the care for the patient, but second there is the education, and third there is the research, and they need to have research facilities, they need to have the educational facilities, they should be able to offer all possible diagnostic tools, all possible treatment tools. This is actually reserved for the happy few, a few centers in Europe. I do not think we should have more than 15 to 20 throughout Europe, a couple in Italy, a couple in Germany, the Netherlands, Belgium, and so on. And this is going to be really the top stars. And for research and coordinating of research, it will be very nice to have a network of these prostate cancer centers of excellence. Next to the initiative of the EAU, where we have involved all the other disciplines, as I said, there's other initiatives also. It's not on prostate cancer centers of excellence, it's more on essential requirements. And that's the Essential Requirement Initiative is from ECHO, the European Cancer Organization, where EAU has been working with them. And this is actually defining what, wherever in Europe, a patient should get when it comes to clinical care. So this means, is there psychological support, is there all the different disciplines, is there multidisciplinary team discussions when it comes to the patient discussions. So this is a completely different, let's say, accreditation or recognition of centers. This is essential requirements, which is different from the initiative that we have. And obviously this can be applied for other diseases, other GU cancers. It could be applied for kidney cancer, for bladder cancer, for certainly the more rare diseases like penile cancer and testicular cancer that actually go to the European Reference Network, an initiative of the European Commission. We are doing more and more aggressive surgery in prostate cancer. We stopped doing radical prostatectomies in low-risk prostate cancer. These patients go into active surveillance and maybe get to surgery later on. But where we do more and more surgery is in high-risk prostate cancer patients. And we are also doing salvage lymphadenectomies in patients that after a curative treatment, be it radiation or be it surgery, that relapse in the lymph nodes in the pelvis. We believe that we do something, but we are still not sure what is the place of this salvage lymph node dissection. Do we really prolong the patient's survival? Maybe not. We didn't show that yet. But what we have shown, that is, if a patient recurs in the lymph nodes, what other treatment could we do? We can remove them, we can do radiation therapy, or we can just give systemic therapy. This means we're gonna give androgen deprivation therapy. If we have a patient that relapses with his PSA and it's increasing steadily, and we find lymph nodes on the new diagnostic tools we have, like PSMA PET-CT, that is very specific and sensitive, we detect lymph nodes, we would avoid to give androgen deprivation therapy by just doing surgery. We remove the nodes, the PSA comes down, everybody's happy, and the final result maybe will not impact on the overall survival of the patient, but it will certainly postpone androgen deprivation therapy. A number of them will never relapse, so are maybe even cured after a salvage lymph node dissection, but the majority will in the end relapse their PSA. But this might mean that you postpone the initiation of androgen deprivation therapy, sometimes for years. In the end, all prostate cancer patients dying from prostate cancer will be castrated, will have their androgens deprived at a certain point in time. And this impacts on the quality of life. And in my belief, postponing androgen deprivation therapy, this means that this less quality of life span they have to expect in their life will be shorter. I think this on itself is an argument in favor of doing these salvage procedures, be it surgery or radiotherapy. The session that I will chair together with Oliver Grimm from Germany on renal cell carcinoma is quite a variable number of different topics. The first is on minimal invasive surgery. We believe that today, for instance, partial nephrectomy, if we can avoid to give the patient a very painful incision, a lumpectomy, and we can do it with minimal invasive tools, this is much better because he will not suffer so much pain and he will not suffer these late incisional complications. And in expert centers, robot-assisted partial nephrectomy today seems to be oncologically perfectly comparable to what we achieve with open surgery. But there is obviously limits. And this is what the second speaker on the topic will try to highlight, and Dr. Kucik will address this issue, showing that we cannot always propose partial nephrectomy in every complex and complicated case. So I think the audience will learn that there is limits to the minimal invasive treatments for renal cell carcinoma. The second issue addressed is for the small renal masses, what is the place of ablative therapies? Ablation of renal tumors has been proposed to frail patients that could not undergo the conventional therapies that we have. Patients that cannot have active surveillance but that cannot undergo major surgery, they can have these ablative therapies. Sticking a needle, doing radiofrequency ablation or doing cryoablation. Cryoablation is more complex, is more difficult, they mostly need laparoscopic approaches, but the radiofrequency ablation really is a minimal invasive technique that works. It worked in the frail patients and probably it also works in patients with small tumors that are detected because of imaging for another reason. So we need, without having studies, randomized clinical trials, showing that ablation is doing as well or is doing enough good as compared to the conventional surgery, we will need to further exploit and consider it as being an investigational treatment, but it will be applied more and more even without evidence-based clinical trials. The next point is on the neoadjuvant treatments. We know that we have had interferon and interleukin-2 and 5-FU administered to patients with high risk, where we believe that the final outcome and survival would be better if we give them after the surgery in an adjuvant fashion. these drugs. Then have come the targeted therapies, the tyrosine kinase inhibitors, with Sutent and sorafenib and the temsirolimus, the mTOR inhibitors. This all have shown that there is maybe a place, but we still do not know which patient actually might benefit from adjuvant and neoadjuvant treatment. Neoadjuvant is now certainly with the immuno-oncology drugs that have become available and seem to be effective in renal cell carcinoma as well. We will need to further explore which patient maybe might benefit from neoadjuvant immuno-oncological therapies, which patient is at high risk for later developing metastatic disease and might profit from these therapies. And Carmen from Spain will give the latest update on everything that is available today. And that's about the most important topics that we will have on that Saturday morning. I have indeed developed a number of surgical techniques that might carry my name. For instance, the pre-pubic urethrectomy. And it's maybe a funny story why I have developed that technique. I was a resident in urology. My professor was doing a cystectomy. He was then doing a diversion. And it took him 4 to 5 hours to do the procedure. And then he said, Van Poppel, and now you do the urethrectomy. This meant I had to close up the patient, reinstall the patient in a lithotomy position, make a perineal incision and take the urethra out prophylactically in patients that had a higher risk of urethral recurrence. And I was already tired myself, and then I found maybe we can get that urethra out through another approach. And what I actually did, I prolonged the incision over the pubis, I luxated the penis inwards and did a pre-pubic urethrectomy without reinstallment of the patient. And initially it was a little bit looking on how this could be fixed, but in the end it turned out that it took 20 minutes more, not half an hour or 1 hour longer, and it was safe. We had to cope sometimes with hematomas, but in the end the procedure as we do it today, prophylactic pre-pubic urethrectomy, does not prolong the procedure. The patient has no pain perineally, so it certainly has advantages. The second procedure is the percutaneous gastrostomy. Actually, when I did these major surgeries and when I was using bowel to reconstruct the urinary tract, we know that patients in the postoperative period, they can vomit, they have gastroparesis, they have paralytic ileus, and they're very uncomfortable with a nasogastric tube that needs to stay there until the bowels start moving again. In this era today, we have the early recovery after this important surgery, the ERAS protocol. But at the time when I was trained, I hated to have this tube in my patient's nose. We were tended to remove that as soon as possible after the surgery because it was so unpleasant. And then I actually did not invent it. I've seen Turner Warwick doing also putting tubes in the upper gastrointestinal tract. And what I simply did at the end of the procedure was inflating the stomach with air by the anesthesiologist. And then I put a cystofix, actually a bladder catheter, by puncture into the stomach. And it was there and it was left there until the patient was developing transit again. And it was removed after the patient had a normal breakfast without any complications of peritonitis or whatsoever. So I felt this was much more comfortable than the nasogastric tube. As I said, with the ERAS protocol today, there is not too much indication to do that any longer, unless in patients that need really to be with an empty intestinal tract for several days. Finally, there's the end pouch, which is simply a mixture between the Studer pouch, the Houtman. It's an end pouch with an afferent lymph. It's very fast, it doesn't take more than 1 hour. It's uncomplicated. It's a simple terminolateral insertion of the ureters on the afferent lymph, like in the Studer pouch, and it's a very easy and fast procedure, which has been updated with results on more than 200 patients, and that works pretty well. So since 2012, I became Adjunct Secretary General responsible for education in the EAU, after having been the director of the European School of Urology since 8 years before that. Education, in my opinion, is one of the most important tasks of the EAU. It's not only the Congress which we consider to be science, but education is everything the European School of Urology is doing today. At this Congress we have 55 courses that are extremely well attended, mostly by younger practitioners, younger urologists, on all different topics that urology means. This is on lithiasis, on incontinence, on oncological topics. So extremely well attended and beneficial for all these young experts. Next to that, we have ESU courses on national congresses in the countries that ask us to come and get there with 2 or 3 faculty of the European School of Urology and to teach them. We have educational events at any meeting that the EAU is organizing, whether this is on LUTS, whether this is on renal cell carcinoma, prostate cancer, bladder cancer, whether this is the multidisciplinary oncological meeting, the IMUC, that we organize every year together with ESTRO and ESMO. There is hands-on training, there is training on MRI reading, there is training also for radiation oncologists. So we have a very important educational platform. There's also online education. So I think the European School of Urology today, under the guidance of Joan Palou from Barcelona, the place where we are today, has become really tremendous and is a fantastic tool for education. After working in urology for more than 35 years, what would I say to a young colleague? That he has made the best choice he could do. Urology is a wonderful profession. Not only because there is surgery, and this is what the youngsters should absolutely know. The place of surgery, certainly in oncology, will not continue to increase. It will decrease. Why? Simply because we have medical treatments. Simply because we have better radiation treatments as in the past. So there is medical treatments which urologists have always been given. We've always been treating infectious diseases. We have been treating medically also lithiasis. We have always been doing androgen deprivation therapy, anti-androgens. We have given intravesical treatments with cytostatic agents. So urology is not only surgery, and I would advise the younger ones, and this is something that is, in my opinion, very important. There is not only surgery, there is not only robot surgery, which attracts so many young people to urology where robotic surgery is so well installed. Don't forget that medical treatment of urological diseases, be it malignant or benign diseases, is so important. We are not just surgeons. We are not doing surgery for an internist who indicates which patient should have which procedure. No. We see the patient for screening, for diagnosis of his disorder, to do all the endoscopic maneuvers in diagnosis and treatment, and then to treat the patient, and not only treat him with surgery, but treat him with drugs, treat him with cytostatic agents, with immuno-oncological agents that become available, with targeted therapies. So the frame of urology is much larger than just surgery, and that would be my strongest advice to the young urologists. Do not forget this, because medical treatment will increase and will become more and more important to cure the urological patients in the future.